should work now. And yeah, Vikki, you can have the floor now.
Great. Thank you for the invite to chat today. My name is Vikki Madden. I'm an occupational therapist, and I have been working in the field of mental health for the past 20-ish years. I'm kind of scared to admit that it's been 20 years, but here I am. I did my undergraduate degree at McMaster and went on to do my master's in occupational therapy at Western University. Um, and I've been working sort of all over. My career, I think I credit a lot to working at Homewood Health Centre. Some people might be familiar with that facility. It's in Guelph, Ontario, and it is um, has inpatient and outpatient programs, and I've been fortunate enough to work my way around that hospital and gain a lot of knowledge and understanding and mentorship with folks that have worked there. But for the last 6-ish years, I've been working with functionability rehabilitation services and primarily working with folks who are struggling with mental and emotional health issues. I kind of have two roles. So my part role is working directly with people after they've sustained injuries in a collision or they have been on a mental stress leave from work, and we're really focusing on the mental health, emotional health issues that they're having. And my other role is to supervise. So I'm a clinical supervisor for other occupational therapists who are practicing psychotherapy. So it's nice that I get to see both sides of things. When I'm not at work, I have two very active teenagers who play rep sports. So I'm usually at a hockey arena or a baseball diamond. And on those rare occasions that I get to be home and put up my feet, I'm hanging out with my husband, and I have to mention my dog. Her name is Lilo. She's 200 pounds and she's loud. She's a loud snorer, and she's in my office today. So if we happen to hear snoring, that's the dog. So just a heads up. There we go. Oh, I'm just going to go back one. There we go. So I'm not sure how many folks may have had interactions with an occupational therapist, but let's just quickly chat about this healthcare profession. I feel like we're not as well known as some of the other healthcare professionals, and there's a lot of questions about what occupational therapists do because we are so diverse. So occupational therapy.
Yeah, I'm listening to a course at the same time.
I'm,
Oi, what was
I'm having some background
that?
noise if someone could just mute. There we go. So occupational therapy, or OT, is a really diverse healthcare practice. We practice with people across the lifespan. So you'll see us working with young children right up till older adults, people who are aging. And the focus overall of OT is to really improve functioning, really function focused. So you'll see us working with individuals who struggle due to illness, injury, chronic disease, mental health concerns, developmental delays, learning challenges, and some of the challenges that come with aging. And
So,
you might see.
sorry, Vikki, there was just a question before you
Sure.
started. Yeah, someone asked, what did you get your undergrad degree in, and if it's if the degree automatically qualified you for performing psychotherapy?
Great question. Great question. I did my undergraduate degree in kinesiology and psychology. And so there is that background, but to become a psychotherapist as an occupational therapist, after you have your master's in occupational therapy, you have to do postgraduate training. So after your master's, myself and my colleagues have done certifications. For myself, I did some work with U of T and McMaster to get certified in specific psychotherapy modalities. It's a great question. I'll touch on that in a little bit as well. And if there's more questions, we can certainly tease that out because that's a big area for sure. You may find occupational therapists in hospitals. So we're often there supporting folks after an accident, stroke, or surgery. OTs are often working in schools with children. Lots of support around fine motor skills, gross motor skills, working with children who have challenges with ADHD. You'll see us working in the community, and sometimes you'll see us in more of those traditional OT roles, like doing home safety assessment and helping support people to access the equipment that they need. And you'll also find OTs who are practicing psychotherapy in the community, potentially in schools and in workplaces. I find that we kind of fly under the radar because a lot of the work that we do is side by side with our clients. There's a lot of counseling. And so from the outside, it doesn't, there's nothing that stands out that says that's an OT doing psychotherapy. So I like doing these talks so that we can have a better understanding of what we can offer folks and what we can actually do, because there are lots of different professions who can practice psychotherapy. But I do think occupational therapy is pretty unique in the skill set that we bring. So then the question I think becomes, what is OT psychotherapy? And if you were to, Google psychotherapy, there'd probably be a lot of different definitions. So as OTs, what we use as our definition of psychotherapy is what is defined by our college. So the College of Occupational Therapists defines psychotherapy with these kind of three main factors. So it's based on a therapeutic relationship with the client. So it's often not a one-off sort of treatment session or consult. There is a therapeutic relationship that needs to be established. And it's a really structured approach using psychological principles, using psychology. And we're using these psychological approaches for assessing a person and what they're struggling with, what the barriers are, but also in our interventions, our treatment, the direct support that we're providing. And the interventions that we're engaging in as OTs with our clients are focused on examining thought patterns, looking at emotions, and how those might be challenging us in day-to-day life, and looking at behaviors, what we're doing, what we're not doing, with an overarching goal of using psychology to promote participation in day-to-day life, to improve function, to improve performance in the things that people are doing in those meaningful activities and in those meaningful roles. So that might be your role as a parent, your role as a partner, your role as an employee, your role as a volunteer. And that sort of encompasses what OT psychotherapy is. As an OT practicing psychotherapy in Ontario, we are regulated and we do have to have advanced training, as I mentioned. New occupational therapists are not qualified to practice psychotherapy. So after we graduate with our master's, we do have to engage in continuing education and supervision to be able to practice in this area. The continuing education is often doing certifications or courses in cognitive behavioral therapy, called CBT, dialectical behavioral therapy, often called DBT, and acceptance and commitment therapy, which is kind of the new therapy on the block, called ACT. Those are the main three that the therapists I supervise at Functionability use. There's lots and lots of different types of psychotherapy interventions, but those three seem to be best suited and have the most evidence-based treatment outcomes for the folks that we work with. So that tends to be our framework at Functionability for psychotherapy. Any questions about that so far? And I know that we're not a big group, so we can keep it casual. If anyone has a question, just feel free to unmute or put it in the chat or put up a hand.
Hi, do you need to become a registered psychotherapist, or are you a registered psychotherapist?
Great question. So there is a college of psychotherapists and there's a college of occupational therapists. If you're an occupational therapist, you don't have to register with the College of Psychotherapists. We're already recognized that we can practice and call ourselves psychotherapists. If you want to as an OT, you can. But I don't see many occupational therapists doing that because really we're already regulated and we have standards from our own college. So it would kind of be like double duty to also register with the psychotherapy college. But that's a really great question, and that comes up a lot in our practice. So I want to take us back a little bit, and this might help just understanding this process as well around how did we go from OT and how did we get to psychotherapy? So bear with me while I give you a little bit of the sort of origin story here. But occupational therapists have been working in the field of mental health for a long, long time. Back in 1915, with the Canadian Armed Forces, OTs were really pivotal in helping veterans transition to civilian life. We were supporting them through some of the traumatic, emotional struggles that they were having, as well as coping with chronic injuries that they had after coming home. So we kind of really started back in 1915 with a really heavy focus on supporting folks with emotional health struggles. And that's just continued on. Certainly, occupational therapy has gotten very diverse, and you see us sort of all over the place in physical health as well as mental health. But we've been doing the heavy lifting in mental health for quite some time. But before 2006, sort of anyone could call themselves a psychotherapist, and anyone could say that they're practicing psychotherapy. It was kind of like the Wild West because there was no regulations, there was no standards. Any profession could really, kind of put up a sign and say that they were providing psychological services. And it was to the detriment of clients, patients, people who are seeking that support because it was wildly inconsistent. You might go to one person and they would treat your depression, your anxiety in one way, and then you could go to someone else and have completely different treatment. And the background, the continuing education, and the experience of those providers was all over the map. And so it really put the onus on the person who is seeking support to kind of vet their providers, which I think is an important process to do, to kind of interview the people that you're going to work with. But the degree that you would have to do that prior to 2006 was pretty extensive because we did not have any regulations. So what happened in 2006 is that the Health Professions Regulatory Advisory Council made the recommendation that psychotherapy needed to be regulated. It needed to be regulated under the Regulated Health Professions Act. And so this set in motion a great deal of work and effort to figure out, what is psychotherapy practice? What are the controlled aspects of psychotherapy? Who can perform psychotherapy? What does their background need to be? And so it makes sense that this was a big transition. It was a very much an overhaul of the system in terms of psychological services. So it started in 2006. In 2007, we had lots of discussions around the controlled active psychotherapy. It took 10 years for the controlled active psychotherapy to sort of become enforced. Then another couple of years for a transition period for all of the healthcare providers in the field to either align with the regulations and the sort of the rules for practicing psychotherapy, or to transition to a different area of practice. So it was a quite a time of turmoil during this time, where people were trying to figure out if they met the standards, could they continue to do psychotherapy? What did that look like? If we fast forward to today, psychotherapy is now a controlled act. It is absolutely regulated, and occupational therapists were granted permission to practice psychotherapy. And our profession had to do a lot of advocacy and provide a lot of support to demonstrate that we have that capacity. So a lot of work and a lot of change from 2006 to 2024. So you might be asking yourself, who can practice psychotherapy? Because there is more than just OTs who practice psychotherapy, and we're all quite diverse in our areas of practice, but also we have similarities in terms of what is our training and our competence in this area. So there were 6 healthcare professionals identified as being able to practice psychotherapy. And we all demonstrated that we have skills and competence to do so. Each of these healthcare professionals has to have meet their own regulatory standards and their own standards of practice. So there is some differences between the colleges, but overall, all of us can practice psychotherapy. So the people who can call themselves psychotherapists and can practice psychotherapy as of 2024 are certainly members of the College of Physicians and Surgeons. So that's our doctors and psychiatrists, the College of Psychologists, so our psychologists, nurses who are registered with the College of Nurses, social workers, and they will be practicing under their college, the College of Registered Psychotherapists. They're the new kids on the block, the newest college out of the 6. If you are registered with that college, you can also practice psychotherapy, and the College of Occupational Therapists. So each of these colleges have their own standards, their own competencies that they have to meet for continuing education, for supervision, and for continued practice. For OTs in Ontario, you have to demonstrate that you have postgraduate continuing education in the specific field that you practice, and you have to have supervision for a set number of years. So I think we have really positioned ourselves well as OTs to have a really good roster of psychotherapists who know what they're doing. They've taken those courses, they have supervision, and they're partnering with other OTs to practice in this area. So I'm glad that we made the 6, because I think that we are really uniquely positioned to do some great work with folks, especially given our healthcare climate right now. I know a lot of psychologists have not come back to in-person treatment. So since COVID, they've done virtual and they remain virtual. So it's nice that OTs are mostly in person and that we can meet people's needs when some providers are virtual or others are waitlisted. Lillian, I see a hand up.
Hi, my extended healthcare plan covers psychotherapy, but it does not cover occupational therapy. So if I was to receive psychotherapy from an OT, would they be able to bill me under psychotherapy and get reimbursed?
Great question, Lillian. Our the Ontario Society of Occupational Therapists is actually working really hard with insurance providers to update this information, because we've been listed for some time now as being psychotherapists and be able to provide that, but sometimes the benefit definitions are very narrow. So what I've seen happen in the past when this happens is I've had OTs write a quickie letter to that benefit provider to say, as a registered occupational therapist, I'm also a certified psychotherapist. Can you verify benefits before sessions begin, just so that there's no confusion around funding. Depending on the benefits provider, they might say yes, they might say no and need supporting documentation. That supporting documentation might just be the registration number of your occupational therapist and verification that they are practicing psychotherapy. So it's another kind of hurdle to go through, which is a pain when you're trying to utilize extended health benefits, but it's very doable. It's a really good question. We're hoping to shape and change that a bit so that we're clearly identified. But again, I feel like they identify social workers really easily, and nurses who have that background, but for some reason, occupational therapy isn't listed. So we've got some work to do, and certainly the Society of Occupational Therapists is trying to address that.
So just as a follow-up question, that would be
Yeah.
like getting a pre-approval from the insurance company before proceeding.
Yeah, just getting verification, just so that you're not in a situation where you've proceeded with sessions and they decline it and then you have to pay out of pocket.
And then they would tell me how to input, if they approve it, pre-approve it, they would tell me the procedure for actually claiming back the cost of those benefits. Is that it?
Yeah, most providers will have a method or a policy that that they can relay to you.
Okay, thank you, Vikki.
No problem at all. So as occupational therapists in practice, what does psychotherapy look like? So I wanted to give you some examples of the things that myself and the occupational therapists I supervise, some of the things that we're doing. We're working with clients regarding emotional regulation. Sometimes after an accident or injury, it's really hard to control our emotions. We feel a little bit raw, so we might be quick to become overwhelmed or become upset. So we often work with clients to learn emotional regulation skills and practice them. That might include anger, anxiety. There's a lot of fear as well. Low mood. We work with a lot of clients who are struggling with avoidance. They're not really wanting to leave the home or engage in the community. Folks who have experienced a trauma, and certainly working with folks who have dealt with grief and loss related to their injuries. Some quickie examples of some of the things myself and OTs that I'm supervising are doing. I have one OT who's working with someone around vehicular anxiety. They're really nervous to be around vehicles, to be in public transit. And so they're doing exposure therapy on a weekly basis, and they're practicing using public transit in a very graded approach, and using anxiety management strategies to manage panic and anxiety, so that this person can become gradually more and more comfortable with accessing their community, and hopefully have a symptom reduction in their anxiety with the use of exposure therapy, which is a psychotherapy modality. And I think that's a really cool one, because we're side by side with a client going on public transit, and not a lot of healthcare providers are that are not maybe as working side by side with clients as we are able to, which is a really unique benefit of occupational therapy for sure. And so oftentimes when people are asking me, Vikki, what's the difference between like an occupational therapist doing psychotherapy, seeing my psychologist, or meeting with a social worker? And I think that's a really good question, because sometimes on our healthcare teams, we have all three. We have a psychologist, a social worker, and an OT. And what are we doing? And who's doing what? Where's our scope of practice? And so often I refer to what I do as an occupational therapist and what my OTs do at Functionability as functional psychotherapy. And I'll explain that a little bit. How I like to phrase this is that, psychotherapy is really action oriented. And as OTs, we're very action oriented. We're the doers sort of on the team. So when we're practicing psychotherapy, with folks, it's really in partnership. So it is that side by side support, and we're practicing in your environment, with your consent, of course, but we're practicing in your home, in your community, at school, in the workplace. It can be really immersive. So we're in your environment, and that really helps us build skill, but it really helps us generalize skill as well. It's one thing to sit and talk about mindfulness or managing panic attacks. It's another thing to go with your OT. And I did this last week with a client. We went to Costco. It was busy. It's entirely different to go into a setting, have a panic attack at Costco, and work through that with someone next to you. So that really helps us generalize our skills and really helps me understand, well, why did that skill work or not work? And I can see that when I'm with you in Costco, right? And we can problem solve and troubleshoot. And this is all about restoring function. It doesn't really serve anyone if you can practice your skill for managing a panic attack at home when really the panic attacks happen at the grocery store or at Costco or amongst crowds. So I really want to work on the functional goals. If the issue is, at Costco, let's work on restoring function in that environment and practicing in that environment. So I think we're very functionally focused. And I'll talk about how we sort of integrate with the healthcare team as well. Because like I said, we usually don't practice alone. I mean, in certain circumstances, I have some private clients or clients where the healthcare team is now less, but most often we are practicing alongside a psychologist, alongside a psychiatrist, sometimes social work as well. So we have these bigger healthcare teams, but what we tend to find is that a lot of the time, psychology and psychiatry is virtual, or it's in person, but the frequency intensity is low. So you might only be seeing the psychologist once a month, every other week virtually. And, in psychology, you might be working on processing the traumatic event or, doing some counseling around the grief and loss associated with the accident. And that's a lot of work. And psychologists are really well versed to do some of that work with folks. We also might have social workers on the team. And a lot of the times in my practice, we have social workers at Functionability. The social workers are often focusing on the change in relationships that happen after an accident. So it might be supporting you with counseling around how has this changed your relationship with your partner, your kids, your family, at work. And as occupational therapists, we're coming in to do some psychology and psychotherapy work with a client around building skills and practicing skills for managing day to day. Oftentimes we're referred to as boots on the ground. A lot of my psychologists say, like I see somebody virtually, but Vikki, you're in their house, you're at, the park with them, you're at the grocery store. Can you tell me how they're doing? So we're kind of like, we're in those spaces and we're boots on the ground. So we can really have a keen eye on how are people performing and how are they really functioning. You may work with a psychologist or a social worker on some skills, which is lovely. And oftentimes the psychologist will say, hey, Vikki, can you practice this skill that I introduced to the client in your session next week when you go on your walk to the park? So, we can work as a team where the psychologist might introduce some really good skills and we practice it together. And then we give some feedback to the psychologist around what worked, what didn't work. I think another really pivotal role for OT psychotherapists is around crisis management support. So oftentimes occupational therapists are able to see clients at a higher frequency and intensity than a psychologist and certainly a psychiatrist. So we can be really helpful in terms of creating coping plans, helping to manage crisis, connecting with after hours crisis supports and making sure people are familiar and comfortable with accessing that as well. So what I wanted to do before we sort of open things up to everyone to ask questions, I wanted to leave a lot of room for questions. I wanted to demonstrate and give you an example of psychotherapy in practice. So I think storytelling is so important because it's a really nice way to understand the OT psychotherapy role and how that could impact a client and a person. So I'm going to introduce you to a client of mine. The information has been changed and, to protect privacy and confidentiality. So some of these details have changed to protect that. But I want you to meet Linda. So she was a client of mine a few years back. She was involved in a catastrophic motor vehicle accident where, unfortunately, she was injured and somebody that she was riding with passed away. She sustained both physical and psychological injuries in this car accident. So physically, she was diagnosed with a traumatic brain injury. She also had lower extremity fractures, which developed into a chronic pain condition. Psychologically, she was quite severely depressed following this accident. She had a lot of symptoms of post-traumatic stress disorder, and she began using substances to try and cope with all of the overwhelming things that were happening for her. So Linda had a fairly large healthcare team. There was myself, there was a full physical team. So we had a physiotherapist, a registered massage therapist, a physiatrist helping with the pain management, a psychiatrist doing some assessment and intervention related to medications, a psychologist, a social worker, and myself. So a pretty large healthcare team, really trying to provide really client-centered care and treatment for Linda. So when I came on to support Linda, some of the primary and acute needs had been sort of addressed. There was a role initially for occupational therapy to come in and do some work around equipment and home safety. The first OT that was practicing with Linda had set up the healthcare team, really got things, underway, got her some equipment. They had talked about, pacing and energy conservation principles. But one of the things that really stood out with Linda was just like the very profound depression that she was in. And so the occupational therapist who had been working with her reached out to see if we could engage an OT psychotherapist. And so I came on to work with Linda and the healthcare team, primarily to look at some of the challenges around depression and the trauma symptoms. And understandably, because Linda was so depressed and feeling quite hopeless, it was really difficult for her to access the other healthcare treatment that she needed. It was hard for her to go to see physio. It was very hard for her to go out and have a massage, even though these things she knew intellectually, like these are going to help her. Her depression was so profound, she really couldn't get out of bed. She wasn't, changing out of her pajamas. She wasn't really eating. The depression really had a strong hold on Linda, for sure. She was meeting with a psychologist virtually, but there were some struggles with virtual psychology, especially with a screen and being able to tolerate the screen time. So it wasn't as impactful because cameras were off and there was a low tolerance for that. She did see a psychiatrist, but it was every 3 to 4 months, and that was primarily for medications. So we weren't getting much symptom relief in terms of improving the depression, which was really a barrier to her day-to-day function and a barrier for her to access other healthcare support. So when I came on board, my primary focus is building a relationship and establishing a really good therapeutic rapport. So that was, my only goal initially, was to try and understand Linda's experience, try to understand what's important to her. So it says values assessment on the screen, and that wasn't a formal checklist type thing. That was just us meeting over a number of sessions to talk about, like, what's important to you, what are we feeling like we're missing out on, how can I make a difference. And so I remember, the healthcare team saying to me, Vikki, the goal is to get her out of the house so she can access these other services that might really help, which I 100% agreed with. But what does Linda want? And so I remember asking Linda, and it was probably end of November. I said, if you weren't struggling as much with all of the things that are going on, what would you want to be doing? What would be on your, your priority list? And she answered right away. She said, for the last, I think it had been 2 or 3 years since the accident. So for the last 2 or 3 years, she hadn't been able to decorate for the holidays. And she was someone who took a lot of pride in having a totally, beautifully decorated home for the holidays. People would talk about it. People would come over and comment on her decorations. And she hadn't been able to do this for 3 years. So she said, yeah, if I wasn't struggling with this, I would have my house decorated, but I just can't. And there was a number of barriers and challenges that she listed. And so I took the opportunity to do a really functional, focused series of psychotherapy sessions with her. I said to her, Linda, I get it. It seems like a big stretch to be able to put up these Christmas decorations, but use me as your OT. I'm going to come in, direct me, and let's get these put up. At the end of the day, if having the lights on the tree and having some decorations is going to lift your mood even a little bit, that's worth it to me. So she was a little skeptical at first, thinking, what, you're going to come and decorate my house? And I said, yeah, we're going to use skills, and we're going to talk about, ways to do this and kind of address some of the challenges together, but let's just try it. I really invited her to be curious and experimental with me. And because we had built that rapport, even though she was a little bit pessimistic about the process, she agreed. And so we started to do sessions with a primary goal of decorating her house for Christmas. And that's why we've got the Chevy Chase picture up there, because I was really concerned that would be me not doing such a great job. So we did a series of sessions where the initial one, I had said to Linda, just, meet me where you're at. I'll come over. We'll pull out some of those decorations and we'll see what we can do. So the first session, that's exactly what we did. We pulled it out. She directed me, and I did a little bit of decorating. And of course, she pointed out that I was doing it wrong, because nobody decorates your house as good as you. And so we got a little bit of activation. She was able to get up. She participated for a short window of time. And that was a great initiation of the task. And so we could talk about, how do we pace? How do we conserve energy? How do we take breaks when we're doing this really meaningful task? So we did some great general OT interventions in there. By the second or third session, I showed up and I noticed that instead of wearing her pajamas, she had changed her clothing, and she was getting into the spirit, because she changed into those ugly holiday sweaters that you get around the holiday time. She had her ugly holiday sweater on. So we were seeing some even more activation in between sessions, because this was a meaningful activity. And sure enough, she had pulled out some of the decorations herself. So she was challenging some of her own beliefs about her capacity, the things that she could and couldn't do. And she got this, she had told me there's no way she could get these things out and be prepared. which was fine, but she was actually doing that. So she got up, she decorated with me, and already we saw an increased tolerance for activity with that. She was able to engage in that, and it was hard work. So there was times where we pulled out ornaments and she was overwhelmed with emotions, and we used that time to introduce some mindfulness. We did some breath work when we were feeling like we were getting overwhelmed. At times, we did some self-compassion practices, took a purposeful pause to help with some of that emotional regulation. It was interesting because throughout these sessions, we were also gently challenging and examining how she initially thought, how she, initially thought her pain and her symptoms would be restricting her in this activity, when really she could actually challenge her symptom threshold a little bit more than she thought. So it was interesting to see her shift her mindset into something of like, I cannot do that, to, well, maybe I can, or maybe I can do a little bit. So it was really interesting. I must have mentioned at some point Mariah Carey, and the fact that I love Mariah Carey at Christmas time, and that I embarrass my kids by singing Christmas tunes, Mariah Carey in particular, because the next session I came, she again was in the holiday sweater. She had found some Mariah Carey Christmas tunes, and we had a great session, and you could really see the shift in her mood. She was lighter, brighter. She could laugh. Well, I mean, if you heard me sing, you'd laugh too, but she was laughing at me. We were laughing at each other singing, and it was a really like very different mood and different session than when we had first started. The last session I came in, and she was 100% Christmas. She had showered. She was in her ugly Christmas sweater. She had those tights that you could get, those themed tights. So she had like candy cane tights on. And I'm smelling something like delicious. She had gotten the Pillsbury, the easy, just cut and bake Christmas cookies, and had baked cookies. So this was like blowing my mind, because she was someone who was not getting out of bed, who was not eating. And because we had this focused sessions around Christmas decorations, it had really led to activation. And this is a psychotherapy strategy of behavioral activation, which leads to shifting mood and improving function. So it was amazing that we got this house decorated together. She participated with modification of task, with pacing, while using some great psychotherapy strategies to manage emotions. We did a lot of challenging around some of the thoughts she had about her pain and symptoms, and she really worked on self-compassion throughout, because she was so hard on herself. So, knowing where we started and then where we ended, it was super successful. And what really it really started the ball rolling, because then we had these conversations after we completed the Christmas decorations around, how can we use this in other areas of your life? What else can we challenge ourselves to be doing? And where can we use some of the things that we did that allowed us to do the decorations? How can we apply that to other things? So the next thing that she wanted to do, she needed to use a mobility scooter for community activities. So she was open then to doing some work with me on figuring out how to use this scooter so that she could get out of the house and feel comfortable, even though she was very anxious using this scooter. So it really got the ball rolling. And at the time of discharge, she was, certainly very community active. She was scootering all over the place, but she was also challenging herself to participate in family activities. And she was planning, right when we discharged, she planned and executed going to a family cottage for a week, which was like a really big undertaking for her. So it was like some really juicy OT psychotherapy, where we really worked on function, but we also used all of these great psychotherapy modalities to help overcome the barriers and challenges that she was having with her emotions, for sure. So I'll stop talking because I could really talk about this subject for hours on end. So let's turn it over to you guys in case there's questions in the chat or anyone wants to put up their hand to chat about anything related to OT and psychotherapy. There's my information too.